Blood administration, advanced nursing skills. Transfusion or transplant. So blood transfusions are transplantations of tissue from donor to recipient. As such, blood must be carefully checked for compatibility. So let's go through the different types of compatibility. We use the ABO system. So each person inherits one of the blood types shown at the right, and compatibility is determined by cell surface proteins. So we have RBC or red blood cell antigens that are inherited. As infants, antibodies develop, and if foreign antigens are later infused, reaction can actually occur. So in this picture, you'll see we have type A, type B, type AB, and type O blood. Our type A has our A proteins on the surface and our anti-B. They don't like B. Our B has B on the surface and they're anti-A. They don't like A. Our AB has A and B and they don't have any that they don't like. They like everything. And then our O doesn't have anything on the surface, but they're anti-AB. Let's go through this more in detail. So here we have 3 circles. We have one circle dedicated for A blood. We have B circle dedicated to type B blood, and then we have another circle dedicated to the Rh positive factors. So A negative is here, and we have A positive. So both our A's are in our A circles, okay? So hang with me here. Then we have our B negative and our B positive. So what we have going on here is we have type A blood, A negative can give to A positive. Negative Rh factors can give to other Rh negative factors and positive factors. So A negative can receive A negative and it can give to, or A negative can give to A negative and it can give to A positive. Same thing occurs here with B. So B negative can receive B negative, but it can give to B negative and it can give to B positive. Now, if you notice here, we have our middle ground. So we have AB negative can receive from B negative and A negative. And then our AB positive can receive from A positive, A negative, AB negative, B negative, and B positive. And then finally, we have our O positive. So our O positive can give to A positive, AB positive, and B positive. All right, kind of catching my drift here. And then we finally have our O negative. Our O negative can give to everybody. That's why it's not in a circle, because it can give to absolutely everybody, but it can only receive O negative itself. So if this was confusing for you, I have another way to kind of help you figure it out. Now, when we look at our graph here, we have our donors and then we have our recipients. So this is our blood donor and this is the person receiving the blood. Now, when you look at this, we have type AB positive is a universal recipient. So it can receive from everybody. It can receive from O negative, O positive, B negative, B positive, A positive, A negative. It can receive from everybody, okay? So it's a universal recipient. Now, AB negative, because it has the negative antigen, can only receive from other negative antigens. Since it's AB, it can receive from O, because O negative is a universal donor, it can give to everybody. But it can receive B negative because it's B negative, receive A negative because it's got A negative in it, and it can receive AB negative. Okay, do you see the difference? Now, let's talk about A positive. Since it's positive, it can receive negative and positive. It can receive O negative and it can receive O positive because O is the universal donor, so it can give to everybody. O negative gives to everybody. Now, O positive can only give to other positives. Now, the A positive can also receive A negative and can receive A positive. But A negative, on the other hand, because it's negative, can only receive negative products, so only O negative and A negative. B positive, because it's positive, can receive that O negative, O positive, B negative, and B positive. But negative, B negative, because it's negative, can only receive O negative and B negative. Now, O positive can receive positive and negatives, but it can only receive O. And O negative, because it's negative, can only receive O negative. So, like I said, AB positive is a universal recipient. It can receive from everybody. And O negative is a universal donor. It can give to absolutely everybody. All right, so compatibility. So let's talk about that Rh antigen system that we kind of already talked a little bit about. So Rh negative are born without antigens. So what's the most common method in which Rh negative humans are exposed to Rh positive antigens? Well, childbirth. But most transfusions are important too because it can cross over then if you don't get the right antigen that you're giving. So we learned this in health promotions that the Rh negative mother has carrying a Rh positive baby, and during delivery, blood gets mixed, and then mom now has Rh positive in her blood. Well, she needs to get ROGAM, so that way her body doesn't kind of fight off the positive. Otherwise, it'll kind of attack itself. So again, we give that ROGAM for Rh negative mothers who give birth to Rh positive babies. Transfusion indications. So, when do we give transfusions? So it's used to replace and increase blood volume. It helps to boost the oxygen capacity of blood and then improve coagulation. So what are some symptoms that our patients may present with if they have decreased blood volume? Well, they may have hypotension, confusion, loss of consciousness, brain or organ damage, or even death if they lose too much. So let's look at the different types of products that we have. We have whole blood, which consists of packed red blood cells that has frozen red blood cells and washed red blood cells under it. And then we have platelet-rich plasma that has platelet concentrate and then plasma, which can be broken down further into frozen plasma or fresh frozen plasma. Now, our frozen plasma has albumin, GABA globulin, and other clotting factors, and our fresh frozen plasma has our cryoprecipitate. All right, now whole blood. So we're going to kind of work down some of that list. Whole blood contains all components, meaning it's got red blood cells, white blood cells, platelets, plasma, which includes plasma proteins, antibodies, waters, and electrolytes. It's a volume expander, and that's usually good for someone who's in shock or has trauma. And it's typically used for volume expansion when someone's lost 25% or more of their blood. So it has spike proteins, which promote coagulation, and it's actually kind of rarely used at this point. So today we use the appropriate component of blood, very whole blood, and it's less wasteful and decreases the chances of some reactions and volume overload. So we don't waste what we don't need. If we don't need the plasma out of there, then we're not giving plasma anymore. We just give them packed red blood cells instead of whole blood. Less wasteful. All right, whole blood cell infusion. So first things first, we always assess our patients, no matter what type of transfusion we're giving. We need to assess their lung sounds, we need to assess their vitals, we need to check their IV site, which is even important as well, because we don't want to get down to the room with whatever our product is that we're giving and the IV site's no good. Now we're wasting time trying to start the IV while the product is sitting out. If it's out for a half hour or getting close to that half hour, it needs to go back to the blood bank. So it's pretty important that you have your IV patent before you go to the lab to collect the transfusion. Again, no matter what type of blood you're giving. Now, we also give it through blood tubing and a filter, which is specialized filter. It's usually a Y tubing. We hang with only sodium chloride, that 0.9% sodium chloride. We infuse all of them at least within 4 hours from the time that we take them from the blood bank or the time that we start it. We need to start it slow. So start the turtle slow at like 75 to 100 milliliters per hour. The IV should be started at. We don't want to run it too quickly because if they start to have a reaction, then they may have gotten quite a bit of it. So we start it out slowly. And then it's type specific. So we need to make sure that there's compatibility, type, and cross match. So we're giving the right kind to the right person. All right, packed red blood cells are PRBCS. So it's very viscous. We get a new filter every 2 units or 4 hours, whichever comes first. And packed red blood cells, 75% of the plasma is actually removed. It has the same oxygen carrying capacity as whole blood. So why do we use packed red blood cells? Well, there's less chance of overload, and we can use the plasma for someone else. It's less wasteful. And then we give it for severe symptomatic anemia and acute blood loss is most commonly what we use it for. And 1 unit is usually about 250 to 350 milliliters and raises the hemoglobin approximately by 1 point. All right, packed red blood cell infusion. So it's the same as with whole blood. So again, it's thick, and we prefer to use an 18 to 20 gauge. We usually say it's because it can break up the blood cells if the gauge is too small. But another reason why we use the bigger gauges is because we want to get it in a timely manner. We can use as small as a 22 gauge, definitely not preferred because it would take forever to get in there. And 22 gauges are pretty fragile, it can bend and occlude pretty easily. So we like to use those 18 to 20 gauges. We can use wash packed red blood cells with sodium chloride. They wash it with that. And that's usually for neonatal or intrauterine transfusion, or when patients have had recurrent or severe allergic reactions to plasma proteins, or to people who have had repeated febrile reactions to transfusions, or someone who gets transfusions pretty often. They don't want to have them have more reactions. So this will help eliminate some of those reactions or decrease how bad those reactions are. All right, platelet products. Trying to find my slideshow here. All right, so uh, let's look at those platelet products. So you can see our regular ones kind of floating over here in the picture, and then we have activated ones. Those activated ones kind of have arms that reach out and grab other things to help clot off. So that's pretty amazing that that's what they look like when they're activated versus when they're not. They look like little round coins, and then all of a sudden they have little feelers out there to try and catch everything to clot. So that's how they stop bleeding. So it's used for bleeding caused by thrombocytopenia, platelets is usually. It may be contraindicated though in thrombotic or thrombocytopenia purpura and heparin-induced thrombocytopenia, except in those life-threatening hemorrhaging, then we may give it. It's prepared from fresh whole blood and can be pulled from anywhere from 4 to 6 different donors. Typing is not necessary for platelets. After multiple platelet transfusions, though, a patient can develop an anti-human leukocyte antigen, and then antibodies to transfuse those platelets would be against it, so they're anti-HLA. So with the use of lymphocyte typing to match HLA types of donor and recipient, multiple platelet transfusions can be given with fewer complications, those who actually develop antibodies to the platelets. So the patient can be premedicated along with that, with antihistamines like Benadryl, diphenhydramine, or cortisone to decrease the possibility of reaction to platelet transfusions. And then each one of those bags is anywhere from 200 to 400 milliliters per unit. Platelet infusion. So it's given rapidly due to fragile nature over about 15 to 30 minutes. We say it's kind of dumped in. We use a Y-type blood tubing to administer it. We have white blood cell filters that can help people with histories of febrile reactions. And mild fever and chills may occur, which is quite common. So after multiple platelet transfusions, again, that patient can develop the anti-HLA, and so then we can do that lymphocyte typing and then premedicate them to help decrease their chances of those reactions. All right, fresh frozen plasma. So it's a liquid portion of whole blood. It's separated from the cells and then frozen. So 1 unit contains approximately 250 milliliters. Plasma is rich in clotting factors but contains no platelets, so it must be used within 24 hours after thawing. Okay, so it's frozen to help preserve those clotting factors used to treat the clotting disorders. Plasma transfusions are given to treat clotting disorders, used for bleeding caused by the deficiency in clotting factors like DIC, hemorrhage, massive transfusions, liver disease, vitamin K deficiency, and excess warfarin. We do have the ABO compatibility is required. It's infused rapidly, usually 30 to 60 minutes as a client tolerates. Now, cryoprecipitate is prepared from fresh frozen plasma. It's the replacement of clotting factors, especially factors 8 and 9, the von Willebrand factor, and fibrinogen. So again, it treats hemophilia and other related clotting disorders, and it's usually indicated by fibrinogen level less than 100 milligram per deciliter. Now, autologous infusions, the collection and infusion of clients' own blood. A lot of times they can be done preoperatively. You could think someone can take shots or donate weekly if the hematocrit and hemoglobin is within normal limits, then they can donate a little bit every week. So the reason why they do it is because they're guaranteed compatibility to their own blood, and then it eliminates risk of disease transmission. However, there is also a risk for bacterial infection getting into that. Now, blood can be recovered and reinfused within a standard time frame. It's used with joint replacement surgeries, and some of Southwest Wisconsin facilities do this. I don't know of many that currently do that use this Costovac, the blood conservation system, where I've seen it in the past with older surgeons who have them knee surgeries or hip surgeries, and then they have a tube into the patient's knee, and then it's draining the blood into this, and then within like 4 hours, then you push this button, and there's another tube under here that goes to a little bag that fills up with whatever amount of blood that's in there, and then you transfuse it just like a normal um, bag of blood to be reinfused to the patient. So it's pretty neat if you ever get to see it. But again, I don't know that there's many facilities even doing it anymore at this point. Cultural awareness. So about 1 in 350 people are Jehovah Witnesses. They believe blood is removed from the body should be discarded, and consuming blood is prohibited in the Old Testament. Um, Receiving blood or blood products are disgusting or even sinful. So even autologous blood is unacceptable because it's been outside that body. And it's important that nurses show respect for clients' beliefs and show respect in the case of an emergency situation, and they may need blood transfusion. And um, we need to be knowledgeable about transfusing them without their knowledge, or even with their knowledge, and then consent that needs to be given. They may some of them may accept dialysis, heart or lung, or intraoperative salvage as well. Let's talk about transfusion reactions. So, febrile reactions occur 90% of transfusion reactions. Risk is increased for multiple transfusions, so if someone gets multiple ones. Rh-negative mothers also are at a higher risk. Symptoms are usually chills or rigors, which are pretty severe chills, tachycardia, tachypnea, a fever greater than 100 degrees Celsius, hypotension, headache, and flushing. And to help prevent any of those reactions, you can use washed or single donor platelets. You can give Tylenol, antihistamines, PO prior to subsequent transfusions. And then you could also use that white blood cell or leukocyte filters to help filter out any of that stuff. Now, circulatory overload is another symptom or side effect that we may see. So there's a risk that you have increased risk when you give whole blood or a lot of units of blood. If someone's got congestive heart failure or they're older in age, their body just can't handle all that extra fluid. Their symptoms usually are that hypertension, bounding pulses, distended jugular veins, dyspnea, restlessness, confusion. They could be have crackles in their lungs. They can have a real wet cough sometimes as well. Our treatment here is usually to slow that transfusion, maybe give diuretics. A lot of times we give 20 milligrams of Lasix between multiple units of blood, in between each unit of blood, just so that way we can help get rid of any of that extra fluid that they really don't need. Allergic reactions, risk increases with history of allergens or allergies or previous allergic reactions. So a lot of symptoms that people get are the urticaria, the itching, bronchospasms, anaphylaxis, and symptoms can occur during the transfusion and up to 24 hours actually after they get those transfusions. Now, treatment again usually is antihistamine like Benadryl. We can give Tylenol. We can prevent with washed blood components, and again, antihistamine prior to subsequent transfusions or in between transfusion reactions as well. Bacterial transfusion reactions. So a risk would be onset is rapid for that. It's usually greater than 4 hours. The blood component's been out of the fridge for 4 hours essentially. Contamination during processing. Symptoms can be tachycardia, hypotension, fever, chills, shock. And our treatment here is antibiotics. Keep getting page bump. There we go. Acute hemolytic reactions are caused by giving the wrong blood type or Rh incompatibility. Straightforward. That's usually what happens. So you have an antigen antibody complexes that are formed. Transfused cells are destroyed. Inflammatory response in the blood vessels start, and then we have mild life-threatening cases with DIC and circulatory collapse. So a lot of the symptoms that we see are apprehension, a sense of doom, headache, chest or flank pain, tachycardia, tachypnea, and hemoglobinuria. So immediately or after several units, this can occur. So treatment, maintain blood volume and renal perfusion. So first we need to treat shock and DIC if it's present. We can draw blood samples, send the urine specimen to the lab, maintain the blood pressure with IV colloid solutions. We can give diuretics as prescribed to maintain the urine flow. We insert urinary catheter or measure voided amounts to make sure we're monitoring hourly urine output that can tell us how those kidneys are functioning. They may need to have dialysis if the renal failure actually occurs. And then we do not transfuse any additional red blood cells containing components until the blood bank has actually provided newly cross-matched units to make sure that what we're giving is truly what we should be giving. So the most common causes there for this occurring would be mislabeling of blood products and misidentification of the client. So not doing your checks with another nurse or bypassing some sort of safety check that's in place. So management of transfusion reactions. So stop the transfusion, maintain the IV access with normal saline. So then we need to assess. So compare vital signs from those at baseline, assess the respiratory status. If a transfusion reaction occurs, you need to definitely stop that transfusion right away. That's the very first thing you need to do is stop it and disconnect it. We need to assess presence of anxiety or confusion, chills, diaphoresis, pain, jugular vein distension, urticaria, or itching. Nursing management of transfusion reactions. So we need to maintain that patent IV. And make sure I have my right slide here. Maintain a patent IV with saline solution. Notify the blood bank and the healthcare provider immediately. We need to recheck identifying tags and numbers. Monitor vital signs and urine output. Treat symptoms per the healthcare provider order. Save the blood bag and tubing and send them to the blood bank for examination. We need to collect required blood and urine specimens at intervals based on the hospital policy to actually evaluate for hemolysis, and then document on transfusion reaction form and patient chart. And then the blood bank and laboratory are the ones that are actually responsible for identifying the type of reaction that had occurred. All right, so give them your best every day. That's all your patients. So follow facility procedures to help avoid transfusion reactions. Identify clients carefully, assess clients thoroughly, and educate clients and monitor clients in an ongoing manner. So we're constantly monitoring them. So some important points to remember would be take the patient's vital signs before beginning the transfusion so that you have a baseline to measure. If the patient has abnormal vital signs like a high fever, call the primary healthcare provider to clarify when the blood component may be administered or if they want you to continue. Make sure your patient is typed and crossed. Take your golden ticket or your piece of paper that the lab has printed off for you. Take that with you to the lab to get your blood from the blood bank, and then verify with a second lab personnel or 2 RNs before removing it from the blood bank or from the lab, wherever you're getting it from. Administer that blood as soon as it's brought to the patient. Do not refrigerate it on the nursing unit. If the blood's not used within 30 minutes, you need to return it to that blood bank because then it could be considered no good or expired because it's been sitting out too long. Now, when we need to do our double checks, we need to be looking at the name, the date of birth. We look at that blood bank RX number or the R number, such as that TZH1168 on their wristband. And we're comparing their name and date of birth and that blood bank number on their wristband to that blood and to our piece of paper that you see here. We're looking at our ABO group, which is O, our RH type, which is negative, the AB screening, which is negative. And then we're looking at that donor information. We're looking at the component. Is it packed red blood cells? What unit number is it? What's the unit ID number? So that's specific for what donor it's coming from. So we're going to double check that and we're going to read that off. We're going to look at the donor ABO RH, which was O negative. So is it compatible with what we're giving? So we're looking at the cross-match compatibility, the unit expiration date, and then the cross-match expiration date. Then you're going to have a date and a signature from the tech from the lab or the second nurse that gave it to you, who was issued by, the condition of the unit, and that you took it, and the date and time that you took it. Okay. So then when you go through and do all your double checks when you're in the room with your patient, you'll see that you have a place to write that blood bank number. So again, you shouldn't just be writing it from here. You should be looking at like the wristband and everything. Make sure you're writing it down here. You're gonna have your signature, the second nurse that verified with you, and then your pre-transfusion vitals, your post-transfusion vitals. What date and time did it start? When did it stop? How much was given? And then was there a reaction that occurred? And then it tells you what do you need to do if something happened and who did you notify and everything. So it kind of walks you through what you need to do. Now, some final important points to remember would be during the first 15 minutes or 50 milliliters of blood infusion, remain with the patient. If there are any reactions that may happen, they usually occur within those first 15 minutes or 50 milliliters of blood. Most patients, we need to have the routine vital signs per the facility. Each facility is a little different. We must infuse within 4 hours, so that blood needs to be given over 4 hours. And then tubing is only good for 4 hours or 2 units, whichever comes first. So most patients aren't in danger of fluid overload and can tolerate the infusion of 1 unit of packed red blood cells over 2 hours. Usually, the younger they are, the usually faster that they can tolerate that and have more dumped in. And then again, the transfusion shouldn't take more than 4 hours to administer because of an increased risk of bacterial growth in the product once it's actually out of that refrigerator. And never store blood components in an unmonitored refrigerator like the nursing unit. And that's the end of our slide.